All right. Good morning, everyone. Thanks for joining us. A few minutes late. I'm blaming it all on Steve. Steve, that's on you.
Well, I mean, this is our first time doing these, right?
Yeah, it's our first time doing this.
Felt like it this morning.
Our
A little
first-
technical difficulties. It's because it's so cold in this room.
It's not that cold in this
It's
room.
freezing.
It is cold in this room.
Brad has a stocking cap and mittens on.
He does. Yeah, but he wears that every day, even
Scarf.
in the summer.
I have a throw on. No.
Well, thank you for joining us today in Studio Q. We've got a topic that's near and dear to our heart here at QLI. And so I brought in we've been saying big guns a lot on this. We do a podcast, Brad and I together, and we've been using the term big guns anytime we bring in experts. So brought in two big guns today to talk to you about capitalizing on the continuum. So just a quick reminder, if you are wanting some CEU certificate of completion, please do stick around. There's going to be a question at the end of this. So make sure you do answer that. And then in the chat, if you can just quickly let us know if the audio sounds good on your end. That way we can just kind of take a quick little temperature check and make sure that you guys can hear us. So perfect. Thank you, Anita, for being the first one to respond there. So Steve, if anyone's joined us in the past, they're familiar with your voice. But if you could just give everyone a quick little background on yourself, your career here at QLI, what you do, and then maybe just touch on Continue Telerehab as well. That'll kind of bring the full continuum into view for everyone for this presentation today.
Sure. Steve Kershke, been at QLI since 2005, physical therapist by trade. So had the opportunity to work really closely with Brad, right out of the gate in both of our careers, I would say. And then transitioned over to the business side where I work really closely with Tim on the marketing aspects of our QLI business. And then Brad and I have reconnected on the telerehab side with Continue Telerehab. And we've been at that about 3 years now, trying to really develop what we would call an additional level of care at QLI, which happens to be a little bit of our discussion today. So glad to be here.
Yeah. I should introduce myself too, huh?
Well, no, I don't. I feel like I'm kidding. Yes, absolutely.
Don't give us the full bio.
Yeah.
It's really awkward when you just talk about yourself for 10 minutes. So if you could just give a little quick.
Do I talk about myself for 10 minutes often?
Every time. It's terrible. Man. I try to stop you. You don't listen.
Hey, Brad Dexter. I'm a physical therapist. Steve talked about me a little bit already. Been at QLI for about 11 years and been contributing to the Continue Telerehab team for the last 3 and been full-time for the last 2 there as well. So physical therapist, love doing the work that I do, love working in the team that I work with, and ultimately love working with the people that we get to work with along this continuum of care as well.
Yeah, that's it. You guys are doing some amazing things along the entire continuum. So with that said, I think we'll go ahead and launch into the presentation. Please do interact with us throughout. We'd like to make this more of a conversation than listening to just Steve and Brad talk to each other. And so if you could use the chat function, use the question and answer, and I will appropriately interrupt them throughout to get some of your questions answered. So
yeah, well, we'll dive in here. Here's why you should care about this. And Tim and I were joking around prior to the webinar that we should have maybe changed the title. The title was a little bit narrow, and honestly, we are going to talk a lot about the continuum. And if you work in the catastrophic space, likely the continuum is pretty familiar. But we also feel like there's a lot more to this discussion than just the continuum. So if you happen to work, just in healthcare and it's a little bit more on the traditional side, we think that there'll be a little bit here for you as well. And likely Brad and I will use some personal examples with our kids and coaching and things like that. And so hopefully there'll be something in it for you on a more personal level. A lot of it is really subconsciously helping Tim make sure he develops good habits and things like that.
Yep, so absolutely.
So Tim, make sure you're paying attention.
I usually fall asleep, so I'm like, I'll keep my eyes open this time, I promise.
So, really, we're going to touch on 4 different things today. We're going to start with the learning concepts. These are some mantras that we've developed internally at QLI. There's certainly nothing groundbreaking. And in some ways, we've restated what's out there in the world. We've also maybe put our own spin on it. So we'll touch on that very briefly. We'll talk a little bit about the continuum of care and show what it looks like, standard, and then maybe where some areas that there should be at least some pause or some concern if things don't go as planned. We'll also talk about the importance of transitions, and those are definitely areas that will really get into some depth and end up with some delivery model discussion. So those will be the 4 areas of focus today. We're going to start with the learning mantras though, and hopefully quickly move through these. We'll reference these throughout. So that's really the reason why we're hitting them right at the beginning. This is a full presentation in and of itself. So Brad and I could spend a lot of time talking about this, and that'll be for another day, hopefully, Brad. So let's make sure that we hold ourselves accountable here and buzz through these. So I'll kick us off with the first 2 that we like to start with, which is motivate with meaning and identify the interferences. Really, motivate with meaning is this idea that we all have some sort of purpose in our life. And whenever we are tackling a new problem or simply getting out of bed every single day to tackle the world, we have things that are meaningful to us, that really drive us and motivate us. And they are the things that really push us to put in the extra effort and really be engaged with what we're doing each and every day, whether it be work, school, maybe picking up a new skill, whatever that may be. So whenever this is not in place, we find it to be pretty problematic when it comes to learning and being engaged. So this is often where we start, and closely second to this is this idea of identifying the interferences. And what we mean by this is, what are the barriers to learning a new skill, taking in new information? In our case, navigating through the continuum, there's a lot being thrown at the individual who has the injury, the family, and in some cases, the medical professionals that are helping them navigate that. And so if we don't understand, what's motivating someone to, tackle this big problem, and what are the interferences to their progress, then we are going to be, in a pretty difficult spot right out of the gate. One other thing I should have started with is, these mantras aren't necessarily linear. And so I'm going to kick it over to Brad to tackle his next favorite one. But the reason that you see this illustration here is that you can bounce from each mantra, and they're not linear. They're not necessarily even cyclical, although there is a bit of that happens throughout. So we're going to go through these in somewhat of a linear fashion, but they are absolutely not linear. So Brad, after we talk about motivate with meaning and identify the interferences, where do you want to go next?
I want to hit on step outside the comfort zone. So there's just a basic physiological principle of like, hey, your body responds to the stresses that are put on it. And, if there's too much stress, it can fail in some ways. And if there's too little stress, it's not going to grow. It's not going to build, right? And that same concept we can apply to learning really easily. If we're just in this comfort area, we're really not going to progress, grow, learn very much, right? And on the other side of that, if we go maybe too far out of this comfort zone, we may fail, and we may not actually learn because we're failing. And so there's kind of this sweet spot that we need to get into that's outside of the comfort zone, where we can learn best, we can grow best, right? And so real quick example of that, hey, I'm trying to learn a new picking pattern on my guitar. If I just played a song and stuck with what I knew, I wouldn't get to a point where I could play that picking pattern. If I try to play it too fast, I'm not going to get it down either. So I have to kind of take it slow and kind of build and grow from there, right? And then another one that I think is just really important too is support for success, near and dear to my heart. Just making sure, as a coach to kids, and Steve, you can relate to this too, like we're always kind of analyzing, hey, what amount of support are we giving? Sometimes you and I have talked about this, we give too much support. Maybe that's verbally, maybe it's too hands-on. We just need to let them play in some ways, right? And so we're always having to kind of analyze and calculate what's the right amount of support. And we need to do that with the clients that we serve on a regular basis too.
Yeah, I think a big piece of this is understanding what is going to happen when we, push someone outside of their comfort zone, and what's normal, and then analyzing, okay, this is a little bit too far, not quite far enough, and where does the support fit in?
And that's always moving.
Yeah,
too,
it's
right?
always going to change, and that part is cyclical, right? So once we push someone outside their comfort zone, if they learn, hopefully they're going to be back in their comfort zone, and we're going to have to raise the bar again, and the support is probably going to follow. The other thing I think that is closely tied to this is tied to the task. What this really means is we have to create a training environment that is as closely tied to the end goal, right? And so if we're talking about baseball or basketball or golf, hopefully we're breaking down some of the skills that are needed to perform in the game or in the match, and those happen during practice. But at the end of the day, they also all have to be put together and and implemented together on game day. And in our world, we're talking about real life, right? So when they're in our post-acute facility or when we're seeing them on tele-rehab, we are using training activities that are oftentimes little pieces of the big picture.
Mm-hmm.
And then once we send them off into the real world, we hope that the individual can navigate that. And we might have to provide some support for success there as well. And there's going to be some more challenges that we can't necessarily train on, but hopefully we've set them up for success. And once they get there, they're in a good spot. And then the last one is repeat, repeat, repeat. This one I think is the most obvious, right? This is pretty mainstream in the sense that when you are learning something, the more that you repeat it, the idea is that the more quickly you're going to adopt whatever skill or take in the knowledge that you need. But also the more that you repeat it, the more long lasting that it is.
Mm-hmm.
Where I think we really thrive here at QLI, as well as on the Continue side, is how do you maximize those repetitions, right? Anyone can spend 30, 60 minutes and do some mass practice, but we find that to be problematic, right? If that's the only time someone's doing that, let's just take traditional therapy 3 days a week for an hour with you, there's a ton of opportunity that's missed. And what we try to do is give people opportunities to work it within their day so that it is really functional and it doesn't feel like it's a ton of extra work, right? So if we can give them some strategies to say, hey, within your day, can you find 10, 15, 20 extra repetitions? And over time, that really adds up. And then hopefully we get quite a bit of progress. So this is how they all come together. We're going to reference these throughout. And hopefully this gives everyone a little bit of a baseline. Just for let's use the chat here, Tim, you'll have to keep an eye on this, but just for our sake, can you give us an idea of how familiar you are with the Continuum? Maybe just a low, medium, or high, or rank it out of 10. If you're a 10 out of 10, super familiar, that'll give us an idea of how much to spend on this. And then secondly, give us an idea of how often you work with catastrophic injury, because the more familiar the audience is, the less we can focus on some of that background information.
Yeah, we've got a few mediums, 10 out of 10. About a quarter of claims are cat claims.
Okay.
A lot of folks, 9
so
out
it
of 10.
Seems like the audience is relatively familiar. So we're not going to spend a ton of time on this slide here. And we're going to assume for the most part that you're relatively familiar with what happens at each level. So I'm going to, just to save some time, skip ICU and acute care. For the most part, if you have a complex injury, you're going to land in ICU. And the whole point is to make sure you get the person medically stable. And the same thing happens at acute care. Where we end up seeing this fork in the road is after acute care. And the decision becomes, do you go to post-acute care or do you go straight to a community-based situation? And that's really where we're going to dig in today. And at post-acute and community-based, really the ante is upped, right? We're starting to tackle really complex real life activities and strategies to make sure that people can really recover as fully as possible. And so that's really where we're going to spend a lot of our time today. And so just a quick look at the continuum. This is the full continuum. And you can see at the bottom there, those lines really depict the standard length of what happens when the continuum is run through without really any hiccups, right? So someone goes through ICU, a relatively quick stint, assuming there's no big complications, onto acute care, where depending on the injury, it's a touch longer than ICU. Likewise with post-acute, average length of stay here at QLI is about 80 days or so. So that's quite a bit longer than usually in acute care setting. And then in community-based care, right, that's hopefully people are back to life. So when folks leave QLI, about 85% of them go home or to the community, and hopefully they're spending the rest of their life in that setting. And we'll talk about when that doesn't happen. But this is really a clean look at what happens throughout the full continuum in terms of time. Brad, talk maybe a little bit about what happens and how medical intensity and therapeutic intensity are related along the way.
Yeah, so typical correlation here is like his time from the injury, progresses on, the medical intensity is going to ultimately decrease, right? And that's where you see them moving through these levels of care. And as they're becoming more medically stable, therapeutic intensity can increase. So real quick example of that might be someone that's had a cervical level spinal cord injury. If they've had that level of injury, typically they're going to be in a C collar and they're going to have some kind of restrictions, typically 3 months. Hey, we don't want you to lift anything above shoulder height or lift above your head, right? Well, hey, that's an individual that likely is going to need to use their arms for a lot of mobility. And that means that we need to be able to strengthen upper extremity muscles, right? And so their therapeutic intensity really can't meet a level that they need for functional mobility until the medical intensity of their needs kind of decreases, right?
Yeah. Yeah, I think the other thing we start to think about too, in terms of therapeutic intensity, it's just not the physical, right? I know you used a physical example, but as the medical issues start to subside, we can start thinking about, well, how are you going to do emotionally?
Yep.
If there's any cognitive issues, socially, what is your friend system going to look like?
Yep.
Even vocationally, right? Are you going to go back to work, or what are you going to do to fill your day? And all of that starts to look more like real life, and adds this level of complexity. And we have to be able to put all of that together.
Well, maybe just one other thing to add to that is, oftentimes, as the time in rehab has decreased and decreased and decreased over the years, we're trying to throw a lot of these pieces of life at people earlier on in that recovery process, right? And so they're still at a higher level of medical intensity, but they're maybe not ready for a lot of those other layers of life that we're trying to put back onto them. And so you see them maybe have the same information repeated to them over and over and over again, because they just can't hold on to it early on. Right?
Well, and as providers, we have to understand that, right?
Right.
It's a constraint on our end that we have to respond to, which is challenging. We'd love to have more time, but it's really not an option sometimes. Right. And yeah, we do have to, back to the learning mantras, find ways to make sure that we can give them that information in a way that they can digest it. So a couple more on this little graph. What we often find is that early on after an injury, the outcome predictability is much lower than when they move through that level of the continuum, towards post-acute and community-based care. So this is really just a constraint for the providers early on, right? So if I'm an ICU provider or an acute care provider, this is kind of the hand that I've been dealt. Right. And I know that I have to keep someone medically stable, and I'm forced to make some decisions at this point in time, which, to your point just previously, might be a little bit early in the game. And but from our perspective at the post-acute level and the community-based level of care, we can hopefully, if based on the level of expertise, make a pretty good judgment as to where this person's going to end up, how long it's going to take them to get there. Certainly not perfect. And there's lots of variables to consider, but simply due to time, our outcome predictability goes up along the way, right? The other thing to think about is support. At that early level of care in the continuum, the support is extremely high. There's physicians on board, there's nurses on board, and they're right down the hall at your beck and call. Hopefully, as you move through the continuum, that level of support should go down. In some cases, it's a detriment to progress. And especially if they've moved through the continuum too quickly, right? The expectation that they live maybe independently, they might require more care than what they would need if we transition through this continuum at a good clip and make the right decisions along the way. So that's really where we start to get to the decision-making component of this, right? The decisions that we make early on can really impact the level of support someone might need, how quickly they move through the continuum. Sometimes people move really at a good clip and it's appropriate. Sometimes they move too quickly and it impacts things down the road, which really is the fun part of the conversation. All right, so just real quick, you want to talk a little bit about the team that we see from the beginning of the continuum on down to community-based real quick?
Yeah, so just thinking about keeping that last slide in mind, right? So early on, ICU going through that post-acute care, here's just a list, and it's not all encompassing, but these are a lot of the touch points, and there's a high frequency of these people seeing the individuals that are being served too, right? So you have the injured worker, their support system, care coordination, physicians, nursing, PT, OT, speech, psych, life skills, life path, voc, nutrition, and many more that are on board. But again, as you kind of move through that continuum and you get to the community-based level of care, you go from having all these people interacting with one another, maybe within the same facility, to a much smaller list of people involved. First and foremost, the injured person, the injured worker, and their support system, right? And then they're supported by maybe physician care and their therapy cares, right? And again, this list isn't all encompassing, but it's real easy for this to become fragmented or siloed, and to not have good communication, collaboration going on. And so Steve has done a good job of even just putting these in boxes. And ideally what you'd like to see is you have the person, you have the physician, you have your therapies working together. Ultimately with this idea that, everyone is communicating and collaborating on the person and what they're doing to help kind of pick up the pieces of life and help them be successful.
Well, I mean, let's be honest, the ICU level, usually the acute care level, and even at the post-acute level, there are centers of excellence, right?
Yep.
You go to that center to get expertise, and they all happen to be in the same spot.
Yep.
What we're trying to create on the telerehab side is a center of excellence, in air quotes, virtual center of excellence, where we do have all these providers in the same spot. There's a high level of collaboration, and it's this like modified interdisciplinary model, even at the community-based level, which I think is really cool and really unique. So it's possible to do it. We're having some good outcomes with it. But as from a decision-making model, if I'm a caregiver, or if I'm a case manager, I should be looking for this from start to finish throughout the continuum. Wouldn't you agree?
Yep.
Okay. So now let's look at what functional recovery looks like over time. And this is really where we're going to start to dig into where the decision-making happens. But normally, right, we would like to see a gradual level of progress from ICU all the way to community-based care. And we've kind of depicted these transitions right here. And so when we transition from ICU to acute care, acute to post-acute, and post-acute to community-based, at its very basic level, when you transition from each level of the continuum, there is an inflection point. And usually we see a little bit of a decline simply because someone changes their level of care, right? They change an environment. They go from the 4th floor to the 5th floor.
Yep.
Even at QLI's campus, they can go from house 4 to house 6 for whatever reason.
Yep.
They might even have a therapy change that depicts that difference in level of care. But what we know is that if we aren't prepared for that, there's going to be some issues. And even if we do it perfectly, there's going to be some issues. And so we just have to know that any sort of transition is going to create a little bit of chaos. And that's okay. That's normal, as long as we respond accordingly. The other thing to think about is there's lots of those inflection points that can happen even within the continuum, right? So we mentioned a change in therapy team, right? If someone's at the community-based level and let's just say their caregiver turns over, or their spouse decides to move on and there's a separation of some sort, that can lead to a challenging transition. I think of it at a very basic level. You and I deal with daylight savings time. I don't know if anyone else has issues with daylight savings time like me, but it takes me about a week to transition from, spring forward or fall back. And this is just a really small thing that is a little bit of a hiccup in my week or my year whenever that happens. And so this is all magnified when you have an injury. And so as we go through, let's talk a little bit about the risks. So Brad, you talked a little bit about the comfort zone. What do we normally see if someone is pushed outside the comfort zone? Talk a little bit more about that.
Yeah, I mean, they can get really overwhelmed, right? If they're in a position where they just don't feel comfortable and you don't ease them into that, or something changes really quickly, right? They can get overwhelmed and it's going to impact performance ultimately, and ultimately their success.
Well, and then there's a piece of it where we have to identify the interferences too, right? So let me understand why you're overwhelmed, right? We know that we might have pushed you out of your comfort zone. Sometimes it's on purpose. Right. And so let me understand how that feels to you, and tell me your interferences, and let's make sure we navigate those correctly. Because sometimes it's a good thing, right? We do it purposely, but sometimes we push too hard. And if we don't understand all the interferences that are in play, right? I think sometimes on the community-based level, there's a lot going on behind the scenes that we don't understand. And if we don't ask the right questions, then we are going to be missing something. And then we're going to have expectations of performance, expectations of progress that are not going to be met because we don't understand the interferences behind what's going on. So I think it's a really big piece of this. The other thing is this lack of purpose. And I think we see this a lot at the transition from post-acute to the community-based level of care, right? Everything that we do at QLI is really centered around like, what is your life going to look like now that you've had this injury? And when you go home, you're not going to have all this support, and you need something to live for, right? Something bigger than therapy. And so if we don't help that person identify that and then actually access it we know that there's going to be some issues, and then we fall short on the motivate with meaning mantra. But maybe talk a little bit more about how that matches up with the skill generalization and the tie it to the task component.
Yeah, I'm thinking back to an individual that I worked with that horses were his life, right? That's all that he did, and he wanted nothing more than to get back on to a horse. And you know what? You could work on strengthening exercises as a PT or balance exercises all day long, but ultimately those things weren't meaningful. And so they really had to be tied to that ultimate goal for that person. And hey, they were in a position where they're going to be safe enough to do that, but everything that we worked on, if it was, hip flexor strengthening in order to swing a leg over the back of the horse, we tried to do that in the presence of a horse with support present as well, because ultimately that was the task that he wanted to get back to, right?
Yeah, I'm even thinking of Dr. Karen Hux, who's helping us with some speech therapy. She's working with a gentleman who's going back to work, and she is really modifying, using virtual therapy, modifying the skills that she's working on in terms of writing, right? She could basically have him write something very, general, but she's really digging into what's he going to have to do at work and how is this going to translate to his work so that we can get a good picture on making recommendations. And then simply once he goes back to work, how do we actually see how he does with that? So that's another just more cognitive example of how we use that. And then just real quickly, we've kind of alluded to this, there is going to be this level of social and emotional coping and adjustment, right? Especially as you back off the level of support and get them out into the real world. So we have to understand that, and we have to know that we have to train around that and support around that. And then if we move through the continuum either too quickly or we don't make the right decisions early on, we still might get to the same end goal, but it might just take longer to get there.
Yep.
So sometimes we see this where someone goes from acute care straight to community-based, where if they would have just spent a month or two here at QLI at the post-acute level, we might actually be able to push them through that community-based level much more quickly.
Right. Yeah. There's skill acquisition. I've worked with individuals over the years that have maybe done that, and they end up being home with ultimately too much support at home, and they're not doing things that they could be doing for themselves. They come to our level of care, and there's just a skill acquisition process that they go through then and recognize, oh, I can do those things on my own, which ultimately decreases the level of support that they need.
Yep. Well, or we see, we're really just working on walking and talking at a really intense community-based level, but then there's this how do I live life type of deal that gets missed because we don't have the right amount of support or the right amount of intensity. Right? Because it's at the end of the day, the level of intensity that we can provide at a community-based level is just a little bit different than at the post-acute. So we're getting into a little bit of our next piece of this, but there's some decision-making around that.
All right, real quick. And you touched on this, I think, on the last slide, but Pat in the chat made a good point. And she says, I've worked as a case manager at every level of the care continuum. We are another important team member and are also either a nurse or a social worker. So I know you kind of touched on that, but if you could maybe wrap that in, and I think that talk about maybe that involvement too, and kind of where they come into this whole continuum just briefly. And I know you may talk about that.
No, I mean, I think that's a really good point. We don't, I think we've probably been focusing a lot on the injured person and their care, their network, right? But if we gave the impression that there are not lots of other people involved, that is certainly not our intent, because I think there's case managers, there's other medical professionals that we absolutely have to understand that they have a level of expertise first and foremost, and they can be a teammate in this, but sometimes they don't have the expertise that many of the folks on this webinar have, and we have to educate them too. So there is a little bit of a balance there, but absolutely, how do we leverage that expertise when it's there, and then how do we account for it when it's not? And so I think that's maybe where Pat's getting at. Absolutely. It's like, how do we make sure that we've accounted for all the stakeholders and make sure that we leverage everyone's expertise along the way. So yeah, I think that's a really, really good point, and certainly not intended to leave anyone out, because I think we're really looking at this holistically. And for us, it's like, who do we have on board that can be helpful?
Well, it's also kind of a challenge to the people listening to step outside of your comfort zone a little bit and maybe look and make sure that the way that, whether it's a post-acute facility, community-based facility, acute facility, how they operate and look at kind of how they silo things. And so that's our step outside of the comfort zone challenge to you as well.
Yeah, just real brief story here. Just had a a call the other day. So part of our tele-rehab program is, for injured workers that we're serving once a month, we try to have just a short touch base with the individual and the support system and their case manager as well. And the case manager that I was speaking with the other morning just made a comment of, this is so nice. I love getting to hear this in person from you guys and to hear how the whole program's kind of coming together. And it's just different than reading the notes.
Absolutely.
It's so different than reading those. So I know from their perspective, it was really helpful to feel like they were integrated into what was going on with that person's program and just to have the communication.
How about from your perspective? Like, how does that feel for you as a clinician?
To be able to communicate it?
Yeah.
Oh, it's fantastic.
Yeah.
I mean, again, back to the list that we had on there, while they were not all encompassing, being able to communicate and collaborate and have those open lines of communication are always helpful, because it's not, again, we're all working together for the person. So it shouldn't be one person versus another. It should be, hey, how do we all get on the same train and move this thing down the line?
Well, and there's a lot of decisions that need to be made. And oftentimes, especially in the work comp situation, before we bring something up to the injured worker and their family, we might say to the case manager, like, hey, this is the direction we're heading. Is this the direction you want us to head?
Yes.
And is this in line with where you're going?
Yes.
Because if there's not alignment there, that creates conflict, right? Yep. And that might be what's best for the injured person. But if we don't have whoever else is in the picture on board, right, that's a big miss on our part.
Yep.
The other thing that I think we went back to, what does this interdisciplinary model look like and how do we be efficient with that? One of the cool things that I like is that we provide full access to our clinicians, from case management to family members and that sort of thing, because we believe that just is an efficient way of doing business, but it's a really a great way for people to feel like they're involved and they have the information they need so that they can make decisions and they can plan. So there's a lot to that. And it's just really something I think is pretty cool about how we navigate things. And ultimately what we're really talking about is, how do we provide ample support, right? Yeah. We know that these transitions are going to happen. And one of the biggest things that we have to think about is, when someone's going through the transition, do they have enough support to get through it?
Yep.
And that doesn't mean the support is indefinite. It just means they might need a little bit of a boost until they work through it, until we identify the interferences, maybe recalibrate a few things, and then we can back it off again.
Yep.
Right? It's not an all or nothing. It's going to scale up and scale back. But this is one of the biggest things that we think about as someone is going through it. Or if we see someone struggling, maybe we backed off support too quickly, or we overestimated their abilities and just didn't give them enough. So when it comes back to the learning mantras, they all are important, but this would be a really big clue in terms of, if you see someone struggling, let's figure out if they have the right amount of support and maybe bump that up, or even scale it back if we're not seeing the progress. Sometimes there's just too much. Okay, so we're going to talk about some of these decision-making models. Admittedly, this what you're going to see coming forward is really complex. It looks really complex. We haven't figured out a better way to show you what we have in our brains here, but we're working on that. But we're going to talk a little bit about some delivery models and how it looks throughout the continuum, and then specifically at the community-based level. We're going to have to buzz through this because we got about 10 to 12 minutes left, Brad. So real quick, these concepts are fully grounded in behavioral change therapy, right? What we know is we're dealing with people's habits. We are trying to shape behavior. And the nice thing about these models is it appreciates that. And really what we're trying to do is bridge the gap between this like standard clinical approach where you need a professional PTOT speech or a psychologist on board. And how do you transition to that, something that is just more real life, right? And we all have coaches and we all have this idea of health and wellness. And that transition to a health and wellness model, I think, is really important when we're talking about individuals who have gone through a catastrophic injury, because I think there's this mindset that I need to have a clinician in my world forever. And that is not what we're subscribing to. But, we are definitely understanding that we have to focus on all aspects of life. The right amount of support has to be in place. And even as individuals without catastrophic injuries, I have a coach, right? And I use that person regularly. And if we don't have that idea that that's an okay thing, then we might navigate the continuum a little bit differently. And so we're going to consider the delivery approach and justification of care, and certainly the cost effectiveness of care along the way. So Brad, here's the amazing, complicated flow chart.
If you like decision trees, then this is for you.
But to really dig in here really quickly, we're going to skip the acute rehab section, and we're going to assume that someone has navigated through the acute rehab pretty quickly. and get to where we alluded to that fork in the road, right? And you and I talk a lot about like, well, what questions should we be asking right here? And talk a little bit more about how do we make a decision on when is post-acute rehab appropriate, or when should someone go from acute rehab straight to community-based care? Because that's absolutely an option, but there's definitely some things to consider.
Yeah. So there's three kind of main questions that we have here, and ultimately, again, keep in mind that kind of this health promotion and wellness model is what we're looking toward, and what that means is we're trying to help coach the person to a place that they have a high level of self-efficacy, right? And this, what we call an internal locus of self-control. So in other words, they take ownership and they have autonomy over life again, right? And they've been in a position where they've lost a lot of control over a lot of things, and we're trying to help them regain some of that, regain that sense back, right? So, hey, do they have this high internal locus of self-control and self-efficacy? Do they have intermittent formal therapy needs? Or is it a higher level of therapy needs?
Yeah, really, this is like the intensity of therapy, right?
So how intense does that therapy need to be? And then do they have the right amount of cognitive or physical support, or what level of support do they need, right?
Mm-hmm.
And as you kind of go through those questions, and some of you as you're listening, you're probably thinking, oh yeah, that makes sense. I just typically do that naturally, right? If they don't have the right level of support, if they need a high level of therapy needs, and maybe they don't have that internal locus of control or self-efficacy,
or even if their caregivers don't have that, right?
Exactly.
It's about decision making.
Then put them in a position where they have the support that they need,
Mm-hmm.
right? We're looking at a post-acute level of care. You may push them into a community-based level of care, and you may see them really struggling. And it's because, coming back to the previous slide, maybe not the right level of support.
Yeah, it's a big jump, right? And I think a lot of times even we overestimate someone's ability when they transition out of our post-acute program and into community-based.
Yep.
Right? We think that we've trained them. We think we've given them enough repetition. We think that we've given them the right activities to practice. And even then we often overestimate how quickly they're going to be able to make that transition.
Yep.
And so where it gets really difficult is when you can't answer yes or no to all of them, right? So if the answer is no, they're obviously going to go to a post-acute, pretty straightforward, slam dunk. Same thing if you're answering high locus of control, intermittent therapy needs, and they do have this level of ability, then yeah, they're going to go through a community-based level. Where it becomes tricky is when it's like not all or nothing, and that there isn't really a secret sauce to that. But I think there should be some level of collaboration and saying like, okay, what do we think is going to happen here? And do we think that they can, with the right amount of support, get there? Or, that intermittent therapy needs like the intensity of therapy. I think of this with individuals with incomplete spinal cord injuries. The opportunity for that person to get back to a high level of function, walking, whatever it might be, is actually really high. And if we transition them straight to a community-based setting, we might be missing out on that.
Mm-hmm.
And sometimes it's a constraint financially, but gosh, I hope we're asking that question, because that is really what's best for that person. And how do we help them see that that's actually possible? So this gives us an idea, but so once there's some decision making that happens as to post-acute, hopefully people aren't staying in post-acute forever, right? So if at a certain point that intense skilled therapy is not needed, they're going to get kicked over to this community-based setting, and hopefully they land in that health promotion and wellness section, right? One of the things that we talk a lot about, though, is that is not an indefinite thing. It's not a static thing. Just in our lives, we have changes that happen, right? So we always need to be monitoring that. And if there's a status change, either a functional change or there's some sort of decline, hopefully it causes us to question, do they need more support from a medical professional, right? PTOT, speech and psychology in this case,
Yep.
Right? And if that status change is extremely high, in terms of, wow, I'm seeing more function from this person, they could actually benefit from a more intense program. They might go back to post-acute, or they could go to the community-based, right? Or if they're seeing a huge decline, they may need an inpatient program, or they simply might just get kicked back to that more standard community-based setting. So what we're trying to show here is that this is not a linear process, and it's not just a process that stays static. It's always changing. We always have to reevaluate that. Where I think it's problematic is sometimes our reimbursement system is not set up this way.
Mm-hmm.
There's not an alignment in the sense of, hey, they've gotten to community-based, so they're good to go. Where we see it as like, that's not always the case. And it's actually more cost effective if we're really proactive about this.
I think the other important thing too is like all the providers need to be in a position, or you should at least try to evaluate whether this is happening or not, where they're coaching individuals not just to be consumers of healthcare, but to have some level of ownership and autonomy over their own lives again, where they're able to carry these things back out in a community or home setting.
Well, it's a mindset shift too. I think of a lot of our people who are like, no, I want therapy indefinitely. And we're saying like, that's just not healthy. You shouldn't be living life to go to therapy. Hopefully therapy is an adjunct to that, but hopefully we've given you the tools to, continue to make progress, because we believe progress still happens at the health promotion and wellness level, right? Hopefully we've given you the tools and the support to do that. And then, oh, by the way, you can go to the baseball game that you want to go to with your son, and you can go fishing with your friends. You can go golfing or go back to work or whatever the case may be, because that's what it's all about. Right. Okay. So, Brad, this is really your baby here, and we're not going to be able to dig into this a lot. Just for our listeners, we did provide a really an intense slide that follows this up that has a lot of information that we're talking about. But Brad, maybe at a high level, what we're really talking about is at the community-based rehab, there's a few other levels to consider in terms of a delivery model. So really quickly give us an overview, because we also want to talk about post-acute and tele-rehab here.
Yeah. So if you look at top left corner, bottom right corner, I just kind of think about this slide in this way. Ultimately, we're trying to move maybe from that acute setting down to a health promotion and wellness type of setting, right? And that is kind of this process of an individual becoming more functionally able, but also kind of gaining the ownership over their lives again, right? And if you think about the top right corner, bottom left corner, these are different ways to provide the right amount of support for that individual, right? So acute and outpatient, you guys kind of have that in your minds as to what that typically may look like in terms of frequency and amount of time that people
That's just standard therapy, right?
Standard therapy.
2-3 days a week.
A skilled maintenance model might be something where the person is meeting with a therapist once every other week, maybe once a month for 30 to 60 minutes. And that's kind of just a check-in, right? They still maybe need that skilled part, but it's more of a maintenance type of mode if you're used to using those words, right? So it's not a high frequency, it's just kind of these check-ins. And we love being able to work people to that point within our tele-rehab setting to where we're kind of gradually fading the level of support that they're getting. And then this consultative or proactive dental model, if you think about it, you go to your dentist twice a year, you see your physician for an annual visit once a year typically. And that same thing maybe for these catastrophic individuals could be happening more often, where they check in with a therapist once every 3 months or 6 months, just from a standpoint of, hey, I've been going through my exercise program regularly. Here are the things that I continue to work on from a speech aspect or a cognitive aspect. What else could I be doing just to continue kind of pushing myself forward?
Or identify maybe some yellow or red flags
interferences
that we need to tackle, so that we don't land back up in that different level of the continuum, right? So I think there's a proactive approach to this, so that it could be either proactively progressing someone or proactively sniffing out some issues that might be underlying or that might actually be right on the forefront. That's really, really good. So this slide really nicely explains every aspect of that model. We could dig into this quite a bit more, but I think really the point is we want to move through this. There's some decision making that should happen along the way. And if we do it right, we can, again, give people an opportunity to progress, catch some issues before they really become big issues, and then really do it in a way that's cost effective. And all three of those are really, really important. All right. So this is kind of the flow chart model of what we just talked about. So we're not going to dig into this too much, but this is kind of what it looks like. It gives you a few questions to ask along the way. If you get hung up, hopefully you can refer to this and say, okay, where am I at? What might they need? What are some of the things that I'm seeing? Plug that in there, and hopefully a nice answer gets spit out at the end. We need to do this like a slot machine.
Oh,
right?
yeah, there you go.
Pull it and just like pops out. So hopefully we can figure that out. So real quickly, a couple things to think about when you're easing transitions, right? We share information proactively. This is pretty standard, but really what we're getting at here is identify the interferences that are in play. If you can identify what those are, you can navigate those a bit more quickly. We find that understanding and setting expectations is really, really important, right? What are the expectations of the injured person? What are the expectations of their family? or whoever that network is for them. What are the expectations of the payer, the case manager, right? If we understand what all of those are, we're going to identify, okay, where are we not in alignment and where do we need to kind of recalibrate that? And then how do we move forward and jump right into things very, very quickly? And then everyone talks about deepening and building relationships, right? Another pretty standard thing, but where we look at it as is like, how do I understand this person's meaning in their life, and how do I capitalize on that, right? So if I don't understand that, then I'm going to be, at a disadvantage. Also planning ahead and getting to work quickly. We see this on the inpatient post-acute side of things, right? We send a liaison out. We're getting a lot of that information. We're bringing it back to our clinical teams. And before they even arrive on campus, we already have somewhat of a plan in place so that those first 2 or 3 days, we can jump in and we're assessing, but we're also starting to get into treatment so that we can maximize their time. Mm-hmm. Same thing happens when they transition into a community-based setting. When someone comes to tele-rehab, we're gathering a lot of information. We might be meeting on that person even prior to that with the case manager and saying, okay, day one, what are we going to do and how do we jump into this very, very quickly? Because it gives that person like, oh, this group is really urgent, right? They have a high sense of urgency. They care about my progress, and how do we show that from jump? And then, we talk about transportation. This is really I suppose it'd be into the post-acute and out of, how does that transportation look? How do we support that person in and out of our post-acute program back into the community? And then do we have the right amount of support, right? We talked a lot about that. And what I would say is, even if you think this person has a high sense of accountability and locus of control, you probably want to make sure that you have some support in place. And you can always back it off. It's a lot easier to do that than it is to add it on after the fact. So just one more plug for support for success. Okay, I'll take the post-acute stuff. Brad, you can take the tele-rehab stuff. We have about 3 to 5 more minutes here. So some considerations on the post-acute side are using a center of excellence and multi-location model. Both of them can have their benefits. Center of excellence, we're certainly biased, right? But what that means to us is that we have our expertise all in one spot. And we're able to really be very intentional about that. We think that it limits the silos and increases the collaboration. And just from a business perspective, we can really have a high sense of what our culture looks like and how does that affect outcomes. At the multi-location level, not that that's not possible. I think one of the biggest value adds here is geography, right? People don't always want to come to Omaha to go to our post-acute program. And that's okay. Sometimes a provider that's close is the right decision. What we always try to push people to do is don't make your decisions simply on geography, right? Because sometimes going for the expertise and going for the right provider actually should trump that. And it actually moves you through the continuum more quickly. You might even get home a bit more quickly, which is ultimately the end goal. There should be some sort of physician oversight and nursing care for us. We have a medical director, 24-hour nursing care. These folks still need that level of attention. We've already talked about the expertise. By the way, if you have a hard time finding their outcomes on their website, that should be a pretty big red flag. Those should be pretty front and center and pretty easy to find. Consider the therapy equipment and technology. For us, we invest a lot in our equipment and technology. It's not the end all be all, but many of these individuals are coming from an acute program where, exoskeletons and overhead walking systems and cognitive apps and things like that are available. We want to make sure that we can make that transition into our program very seamless. And so we provide access to that. For us, family housing is huge. Because we are a center of excellence, we do offer family housing, and it's a great way to incorporate the support system at a really regular clip. It's a really big decision to send someone to Omaha and say, yep, I'm going to be 300 miles away at the very least, even 30 minutes away. That's a really big decision. So family housing is a nice adjunct. We're really proud of our service coordination and discharge planning. This is something that we handle in-house. It's a really nice support for everyone, including the case managers. Usually we have a service coordinator who is the primary contact for that person, and they're the quarterback for the program, right? If the program's going a bit more slowly than we expected, we need to let people know. If it's progressing very quickly, we need to do the same thing. There's a level of accountability there. And then the discharge planning, that's something that if this is done poorly, you have a ton of work that's put in on the front end, but if it's done poorly, everything's going to fall apart. So we spend a lot of time on the discharge plan. We spend a lot of time navigating the amount of support that needs to be happening after that. And then we provide the transportation.
Yeah, so a few things that we hit on a lot for our telerehabilitation program is convenience, access, expertise, right? Those are three kind of big parts of our program. Oftentimes from a convenience aspect, that could be people that are in a rural location. This is the one that oftentimes you're like, well, duh, that makes sense, right? They have to travel 2 hours to get quality therapy. But also within urban settings, people may have troubles with transportation. It's not timely. They end up being late, or they don't have the right support system in place to help them out.
Or it's just annoying.
Right. It's easy to schedule around, and they have the equipment within their home, perhaps, right? The expertise, and I think part of that too is just the collaboration that can happen between multiple disciplines within a telerehab setting. You got to make sure the patient is relatively tech savvy. We have ways around that for individuals that aren't, where we can just direct call them, and it makes it easy to get them up on the screen and to be able to communicate with them that way. And I think we've typically we're over 90% conversion rates on a weekly basis, which means that people show up to their sessions, right? It's easy to get them on. There are things that come up like medical appointments, or a computer is hacked, or different things like that. But oftentimes we have pretty good compliance from a telerehab standpoint. And then, we get the people that as a last resort. They've been through every other model of care, and it's just really tough. And we get them as a last resort, and we're there to help. And we've had good outcomes with that, and we've had tougher ones with that too. So.
Well, and hopefully we become less of a last resort. That's really one of our main goals. Is we don't think telerehab is just a last resort. It's not just a COVID thing,
right?
Which is, I think, really the questions we're dealing with right now. Is it was a great option during COVID because there was nothing else available.
Yep.
Now I think we're running into people are going back to their old way of doing things, which sometimes makes sense.
Yep.
But telerehab, in our biased opinion, has a place long term, and that's really something that we've spent a lot of time with. I'm going to take this one real quick. Just a big piece of this is learning, right? We've talked a lot about learning, and the fact that with telerehab, you can see someone in their environment. There's no substitute for that. Even someone going to a brick and mortar clinic, there's a gap once they leave. And the value of telerehab is we get to see them. We've talked about the value of team collaboration, caregiver involvement. Certainly, we have to consider the level of disability. One thing we won't touch on who is and who is not appropriate for telerehab. It's not a straightforward, list of here's when it works and here's when it doesn't. It's not that black and white. It's a bit more nuanced, but it's certainly a consideration. And we've gotten a lot better at saying, hey, this person is not appropriate. We need them to go in person, or we can be supportive there. So certainly we're not saying it's for everyone. And then they have to have buy-in, right? So one of the biggest issues that we see is if the client or their family, or even like their support system is not bought in, it's problematic. And so there needs to be a high level of buy-in, or at least openness to it. And we can either sell them or not on it along the way. Okay, so just for the sake of time, we're gonna skip this slide, but ultimately, you should expect the same plan of care, the same level of assessment as you would get in a brick and mortar clinic. There's lots of ways that we do that versus virtual and in person, but nothing should really be any different, and that's the really big takeaway of this slide. All right, Tim.
Man, look at those photos.
Man.
Looking good.
I don't have a beard anymore, and Steve does.
That's true. Yeah, it's true. Thank you both. Hey, real quick, I'm going to launch a poll question. So make sure you answer that. We'll get you, that'll be on the screen right now. You can close out of it on your side, Steve.
Stop my share.
No, just close out of the poll. Yep, perfect. So poll questions on there. We did have a few questions, and you'll have Steve here for a couple more minutes so we can hang out. Just real quickly, I know that if you could show some interest in the chat, we've always talked about doing kind of an open forum, provider perspectives for you guys to come in, ask us any questions as a provider that we can be helpful with. If that's something any of you would be interested in, go ahead and just in the chat and maybe, put yes or no, or definitely if it's Steve, or not if it's Steve. I can be the voice. Steve can't, he's tired of listening to him, but yeah, that's always something. I just think it would be interesting to have some of those open forum conversations. So one question we did get, Steve, was if you could talk about how to end maintenance therapy without having the patient regress. And I think this is more probably case by case.
Yeah, this is, we'll try to give not a down the middle answer here on this. Brad, you might disagree, but I'm not sure maintenance therapy should ever end to a degree, right? I think it's how you look at it. So maintenance therapy should transition to a health and wellness situation, right? I think if you look back at our complicated diagram, and so the maintenance therapy must be met with, okay, do they have the right amount of support? Is there a good plan that the person can implement? And then does the support system like understand how to navigate that? And if the answer to those is yes, hopefully there's limited regression. But what we often see is we get people who discharge from our post-acute program, or even in our community-based program, where we give them a plan and they follow that plan to a T for, call it 3 to 6 months. And it's considered probably maintenance in nature. But then once we check back into them, they're doing the same plan perfectly, but the plan's too easy for them, right? They don't understand how to progress it, or the plan might be too hard, or they've ditched it and they don't have time. They don't recognize that they need to call for help. So I think that there's this piece of like, hey, if you run into issues or if it's too easy, this should be a red flag that you give us a call. So there's a level of education.
Well, I think that's why we were talking about how do you facilitate that transition to health promotion and wellness model too, right? So there's a skilled maintenance model, there's a consultative model. And so how do you even keep those touch points with a therapist on in the same way that you or I would go to our dentist once or twice a year, right? We go to make sure there's nothing wrong with our teeth or our mouth, and we get that checkup, we get our teeth cleaned. It's preventative, right? And so we need to start thinking, instead of responding reactively to something, how do we prevent something from happening? And a big piece of what we do is we're trying to establish routines within a person's life in their home. And in all reality, I've started routines in the last couple of years that have fallen off after 8 months, and I've had to like start over again 2 months later. And I'm sure a lot of you guys have as well. And we're going to run into those same things with the clients.
Yeah, I think one of the things that helps me buy into this is that I have routines too, and I need support too. And so just because someone has an injury, it almost means they need more of it, right? Especially if they have some cognitive issues or there's other variables involved. But they're very similar to us. They just have different routines and habits that need to be upkept, rather than me trying to go to the gym every week or doing whatever I'm doing. So I just think that we have to see these individuals as people just like us, who have habits and routines that need to be upkept. And what do we benefit from? And let's not make it too complicated. The other thing I would say is this doesn't mean like 1 hour of therapy, right? A lot of times we can check in with someone and it takes 5, 10, 15 minutes. Sometimes we don't even charge for it. Right. It's not even really about the revenue generation. For us, it ends up being like, how do we help them with a sustainable plan that they can implement on their own? If that means that we have to check in with them a little bit and that's on the house, great. We'd rather that sometimes than having, to figure out, the payment component of it. So
for sure. And then Katrina, you did ask a question, and Steve was more just around, does someone have to be inpatient at QLI to use Continue Telerehab services before getting admitted or being accepted as a Continue client?
Easy answer. No.
The
reason we built our telerehab program was really twofold. One, we wanted it to support our discharge planning from post-acute, right? It's an efficient way for us to transition people from QLI to their home. We get admissions from over 25 different states every year. And so that can be really time intensive. And not that we don't visit people's homes with them in person, but we can now make that transition to our telerehab team and really sustain some of that progress that's made inpatient. So that is one way. But there are lots of people who don't make it to QLI for whatever reason. Either they don't want to come to Omaha, or they don't fit our admissions criteria, or related to that, like they just don't need an inpatient program, right? So this allows us to increase our geographical reach and ultimately help more people. And that's the really motivating thing for us.
Yeah. And I think just a quick side note on that, like we did not build this in response to a pandemic. We built it 2 years prior to a pandemic starting, right? And we were fledgling during that time, but it was in response to those things, to support our discharge planning and to give opportunities to people that maybe didn't have them.
Well, and I think we really believe this, these are the conversations that we would love to have, is we believe this should go toe to toe with brick and mortar outpatient therapy, right? We believe in many cases that it's comparable to outpatient therapy, and in many cases it's actually superior to that. And I know that might be a polarizing comment.
So you want people to challenge you in an open forum
yes,
style
conversation? Yes, please. If anyone wants to show up for that, I would 100% show up and participate in that. That would be so fun.
I think so too.
And I think there's the reason we pose that question is because it's not straight down the middle.
Mhm.
And I think there's lots of areas that we probably overestimate, but I think people often underestimate the capabilities of telerehab. They see it as a fad. We don't think it's a fad. There's really some really great outcomes that we've had, and we've gotten people from a brick and mortar clinic and we've had better outcomes. And I could give lots of examples of that. So
Sure.
That's a really fun part of this.
Yeah, definitely. Well, thank you everyone for joining today. Thank you, Steve. Thank you, Brad. This was a great presentation, and be on the lookout for an invite to an open forum. We'd love to have you join us for that, as well as an invite for next month's webinar coming up. So as always, we appreciate you joining, and we look forward to you joining in the future, and be on the lookout for your certificate of completion. You'll be getting that before the end of the week. Taylor is amazing. Typically gets that out this afternoon. So with that being said, we hope you have a great rest of your day. Take care.